So let's talk about scalp DHT, or just DHT in general, in the tissues surrounding the hair follicle. So the medical literature lets us know of two competing theories concerning DHT in the scalp tissues after oral dutasteride and even oral finasteride use. The first being intrafollicular DHT, and this is DHT at the dermal papilla, or the base of the hair follicle. And then the next being scalp DHT. Obviously, DHT being in the broader region of the scalp. And then there's something else that I've also been thinking. I haven't been able to find a study on this, so I won't include it in the quote-unquote competing theories. But there is possibly a way to assess DHT levels in the sebum secretions of the scalp. So this would be DHT primarily coming from the sebaceous glands, which could possibly give us a good indication on how much impact 5-alpha reductase inhibitors can kind of change and modulate sebaceous gland activity. But in any case, let's just focus on the intrafollicular DHT, being the DHT levels around the dermal papilla, or the base of the hair follicle, and scalp levels of DHT. Now, we all know that one study, right? The Olsen et al. 2006 study. And this lets us know that between 0.5 milligram up to 2.5 milligram of dutasteride, scalp DHT is reduced respectively by 50 to around 80%. This study was done for only 6 months, so there's some debate if the 0.5 milligram dutasteride group could have caught up to the superior hair count number seen in the 2.5 milligram dutasteride group. It could be that it does, and the apparent superiority of the 2.5 milligram dutasteride group is merely due to the drug reaching a steady state concentration sooner and thus having its positive effects realized sooner than the 0.5 milligram dutasteride group. And we can understand this pharmacokinetic and pharmacodynamic principle by examining the Ghislain-Coggs study on dutasteride's pharmacokinetics and dynamics modeling, where 2.5 milligram of dutasteride reached a steady state concentration in the blood weeks before the standard 0.5 milligram dose. In any case, we can confidently say that the superiority could be seen in the large differences in scalp DHT that was maintained in the course of the study, which kind of lets us know that dutasteride at either 0.5 milligram or 2.5 milligram or up to 2.5 milligram reduces scalp DHT substantially. And the real superiority, if we had to indicate anything, could possibly be in the fact that the 2.5 milligram dutasteride load had a greater difference in terms of its reduction in scalp DHT by a pretty marginal amount, right? You're dealing with about 80% scalp DHT reduction on 2.5 milligram dutasteride versus 50% scalp DHT reduction on 0.5 milligram dutasteride. So that difference was maintained throughout the course of the study. So that's kind of the direction where people are going in when they say 2.5 milligram is just better, right? And that's what the study is essentially showing, given its 6-month study duration limitation. Now, in my opinion, I would say that the 0.5 milligram dutasteride is enough in most cases, probably a substantial amount of cases, and the 2.5 milligram dutasteride is something that, you know, if you really want to be sure, right, just perhaps that could be something to consider, right? 2.5 milligram dutasteride, that is a surefire way of knowing that, okay, you're going to get the most scalp DHT reduction you can possibly get given the clinical data that we have. So that would be for somebody who has a super sensitivity to scalp DHT. But again, I can't necessarily say that the 0.5 milligram dutasteride is completely inferior to the 2.5 milligram dutasteride when it comes to getting those hair counts, right? Because we know that in AGA, you just have to bring it down a specific threshold, right? You have to bring the DHT down to a specific threshold, and then the hair follicles can flourish and grow their hair. So if I had to bet, I don't think there are that many people who are so sensitive that they need 2.5 milligram to maintain their hair in the long term. So there could be a protocol that I could see where 2.5 milligram is tried for about 6 months to a year, and then from there the person drops down to maybe 1 milligram dutasteride or 0.5 milligram dutasteride. But in any case, go talk to a doctor. I'm not a doctor. just be safe, because when you go to the 2.5 milligram dutasteride group, as it was shown in the Olson et al. 2006 study, that the group that was using 2.5 milligram dutasteride had a higher rate of sexual dysfunctions. I think around 10% to 13%. But in any case, let's look at the other theory, right? The intrafollicular DHT, being the DHT at the derma papilla or around the hair follicle. So I'm not going to be going too in-depth into this study, but there's a study by Yoshikata Hobo et al. 2023, and although it's retrospective in nature, it found that dutasteride reduced levels of intrafollicular DHT, being DHT at the derma papilla or around the hair follicle, by over 95%. So what did they do to get this data for this particular study by Yoshikata Hobo et al.? Well, it's retrospective, so that means they gathered pre-existing data. So they found men who were already using finasteride, already using dutasteride, men who were using either finasteride at one point earlier within a year and then dutasteride later, or vice versa. They were determined to be the dual finasteride-dutasteride group. And the researchers compared the levels of DHT that were at the base of the hair strand that was plucked out of the hair follicle, or, the white part, right? The derma papilla area. And from there, when they synthesized the hair follicle, they found the greatest reduction in DHT for the group that used dutasteride. For the group that was determined to have both dutasteride and finasteride detected in their hair follicle, it had about the same reductions of DHT as the group that only used dutasteride. So that being around a 95% reduction in intrafollicular DHT levels. So with all of this in mind, we must understand that losing hair while using oral dutasteride possibly points to a situation in which the problem may no longer be a sensitivity to DHT, but perhaps another issue here is causing poor scalp hair growth and scalp health. And there are many diseases of the scalp that can possibly cause that, right? Seborrheic dermatitis, psoriasis, lichen planopilaris, frontal fibrosing alopecia in a distributed pattern, which is fibrosing alopecia that gives a diffuse alopecia kind of look. Conditions like hyperprolactinemia, issues with your thyroid, vitamin and mineral deficiencies, which destabilize your body. Maybe even microbial life, which is wreaking havoc on your scalp, like folliculitis decalvans, where you have, bacterial colonies that inflame your hair follicles and cause scarring over time. There are so many other concerns that it rapidly becomes more likely that those issues that I stated out are probably a factor, rather than you having a super sensitivity to DHT, such that even 20% or let's say 5% DHT left on your scalp can cause your hair loss. No, that is probably not the case. It's less likely that that is the case. And this is why you need to get a scalp biopsy. And people need to understand, right, when you've been dealing with a chronic scarring condition of alopecia, like lichen planopilaris, if you've been dealing with that for, let's say, 5 years, even if you treat it, it doesn't mean that the hair is going to come back, right? So, I've talked to people where they're like, oh, well, I got a scalp biopsy, I have DUPA, it says that I have lichen planopilaris, and I've been treating it for a year, yet I'm not getting any benefits. Did I really have lichen planopilaris? Well, yeah, you did, if that's what the biopsy determined, but also at the same time, let's be real here, right? If you had such a horrible condition of the scalp and it destroyed literal hair follicles, what are you asking for, right? It's very hard for any hair to come back in that condition. The only thing you can do or hope to do is to arrest the disease progression, right? To stop the progression of whatever's causing your hair loss and hopefully just kill it or remove it or limit it, just stopping, right? Let's just be simple with the terminology here. Just stopping the bad thing that's happening to your scalp. And you can find out what that bad thing is by getting a scalp biopsy. And once you get that scalp biopsy, you get an understanding, right? You understand what could be contributing to your hair follicles just getting absolutely decimated. And then from there, you can possibly take drugs to kind of remedy that, right? If you're early enough and you catch your lichen planopilaris, let's say that's what you have, for example, It's a defect of the PPAR-GAMMA receptor, right? This receptor is responsible for metabolizing lipids. If this receptor is not working properly, it leads to lipotoxicity, and this causes your immune system to send your lymphocytes to infiltrate various tissues in your hair follicle, and it could lead to a destruction due to a mass inflammation caused by these lymphocytes as they're trying to destroy whatever's producing the sebum, either being your sebaceous glands, your sebocytes, etc., etc. And once this happens, this large-scale inflammation can potentially destroy your hair follicle. It can potentially destroy the stem cell bulge matrix area where the hair follicle stem cells are, which are very, very crucial for activating your hair follicles to even grow. Okay, so let's just be real here. If you have been dealing with that for years on end and you have that condition, taking something like pioglitazone hydrochloride between 15 milligrams up to 50 milligrams can reduce the disease, right? Can stop the disease outright in some people, but it doesn't necessarily mean that those hair follicles are going to come back online, especially when that stem cell bulge matrix area, that area that has your hair follicle stem cells, are destroyed. If that area is destroyed, those hair follicles are unfortunately a casualty of the war that the alopecia condition was raging on your scalp, and you just have to move on from that and possibly hope that the hair follicle stem cells are still alive in some areas, such that when you take something like pioglitazone to reduce the, let's say, again for the example, to reduce the lichen planopilaris in that area, that if that disease is gone or limited, that the hair follicle stem cells can replenish the hair follicle organ, and thus you get hair growth in areas that were being suppressed. So hopefully that made sense as we move on with this video.